Patients will come and say, Doc, I am forgetting. Is it dementia? Dementia emerging epidemic. Now we'll talk about this forgetting. Dementia is a diminishing mental faculties. That is dementia. Please remember, dementia is a symptom like a fever, like a seizure, due to several causes. Alzheimer's is a specific diagnosis. Like I said, seizures doesn't mean epilepsy. Epilepsy is a specific diagnosis. Similarly, everybody who has got dementia is not Alzheimer's. So when people ask me what is this dementia, I tell them, look here, you have heard of liver failure, you have heard of heart failure, kidney failure. Now this is called as a brain failure. Brain is the master organ. Obviously, the master fails last. Look at the prevalence of dementia. At age 63%, if you reach age 80, 30 to 40% have dementia. By 2020, 70% of all patients are in developing countries. In 2017, 50 million people are suffering from dementia all over the world, and by 2030, 82 million people. If you look at this, the life expectancy when we got the freedom in 1947 was just 32 years. And 1960, it has become 40 years. Now in 2019, it has become 70 years. Side effects of living longer. Everybody doesn't live like this, living well. So most of us live like this. So living longer does not mean living well. Now, how does a patient present to us in the clinical consulting room? Presentation one, Doc, I have memory problem. Am I developing dementia? He is already diagnosed. I have already diagnosed myself on the web, but I thought I would come for a second opinion. The another person, amazing. The doctor is saying, amazing your knowledge from the net. If anything, I should be paying you. So when they have so much of information and they're worried about dementia, this is not dementia. A person who knows that he has got a memory problem generally is not dementia, either it is depression or minimal cognitive impairment. The second type of presentation is a couple walks into the consulting room, doctor says, okay, tell me what's your problem. He ask the patient. Patient says, I have no problem. Ask my wife, she has brought me here. And the wife gives all the features of early dementia. This is a second type of presentation. The third type of presentation, where there is an advanced dementia, patients are brought at a time when they are incontinent and are unaware of it. You see, the tragedy is that people who are earning money for the family, the dementia is recognized very early because they stop making money because of the false transactions. But people who are retired and just waiting at the house for doing nothing. So till this stage is reached, people will say, it is all old age like that. The time they become a burden to the family, and that is the time when patients are brought to the clinic. Now the core of the dementia is the memory. People come asking for memory problem. If you look at this, memory has got 4 stages: recognition, registration, retention, and then recollection. The registration is the one which is defective in patients of dementia. Now, when you are all in the class, some cases are presented. When you go out, your friend will ask, hey, what type of case was discussed today? Then you'll say, no, yaar, I don't know, I was not attentive because I was all the time worried about my girlfriend scolding me. So if you are not attentive, it is not registered. So there is no memory. In the examination, Viva versa exam, you know the answer, but you are not able to recollect at that time. The moment you come out of the Viva versa room, you say, hey, I know the answer. It was on the tip of the tongue, I could not recollect. So these are the 4 stages of memory. Registration is the one which is affected. Now, what is the clinical approach? When a patient comes and says, Doc, I have got a memory problem, you take the history and find out what are the items which he is forgetting. The diagnosis of dementia is again clinical. So you have to ask the caregiver person, whoever is looking after the person, not the son who has come from America, who brings the father, who doesn't know anything about his daily activities. Find out from a caregiver what are the changes in the memory part. So once you are convinced, okay, there are memory problems, then is it the depression or anxiety, or is it minimal cognitive impairment, or is it dementia? Once you make a diagnosis, it is dementia, look for a treatable cause. In our medicine, we always look for a treatable cause, however rare it is, than making a diagnosis of non-treatable condition. So if very few treatable causes are there, then is it a vascular type of dementia or is it a degenerative type like Alzheimer's? So these are the steps you have to follow in clinical practice. Now let us see the first step. Is it, we have said, okay, patient has memory problem. Is it a depression or anxiety? In depression, it is the patient who complains of memory impairment. That's a very, very important point. In addition, there are other symptoms of depression: apathy, lack of interest, just sitting in one corner, not interested to do all his routine activities which he was doing. You have to really coax him to do some activity. It improves with persistence. There are no neurological problems like aphasia, apraxia, and all. Mind you, in clinical practice, sometimes it becomes very difficult whether it is depression or dementia because both are clinical history based. So if you are not having time to take proper history or you are not getting the proper history because the caregiver has not come, we always give a trial of antidepressants. So that is about the depression. Very, very important, eminently treatable condition. Then the second part is what is called as a minimal cognitive impairment. It is not MCI of Medical Council India. Now, what is this minimal cognitive impairment? That means there is an impairment of cognition, but very minimal. It is very common. 15 to 20% of the people above the age of 60 years have this MCI. There are definite memory lapses as compared to his previous status, both subjectively and objectively. These are common things. When I go to a party, I know the person, I know what he is doing, I know where he is staying, but I forget the name. This is very, very common. Forgetting the name, but you know the person. You give him two names, he will pick up the right name. That is the MCI. If it is a dementia, even if you give the right name, they are not able to pick it up. We all do this after the age of 60. We don't know where our specs are, car keys. Open the fridge. The uh, housewife opens the fridge to get something, and after opening the fridge, forgets why she has come there. So these are all common things which are called as a MCI. More important, how do you differentiate? It is a non-progressive. You ask them, since when you have got this problem? Oh, I sir, 2 ವರ್ಷ ಆಯಿತು, for the last 2 years. Do you think last 2 years it has become worse? No, 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 it is just the same. So it cannot be progressive dementia. So this clue, non-progressive, is very important. And it does not affect the daily activities. Whatever his routine is there, he is able to do. Does MCI mean they are going to develop Alzheimer's? Normally 1% per year of the people after the age of 60 dementia. In MCI, it is about 10%. So 90% still do not develop dementia. So please reassure them it is normal, it doesn't require any medicines. All you have to do is take a paper and pen, write down, which I am doing it on all Wednesday class. You must be seeing that. I write down what are all the things to be done on that particular day on one page, what is due in that week in another page. So I keep checking that. That is the best way to see that MCI is managed. Then we come to the problem of dementia. Now, what are the symptoms of dementia? Dementia has got clinical manifestations like two sides of a coin, the neurological and the psychiatric. That's why dementia is treated by psychiatrists as well as neurologists. They have both the problems. Now, in the neurological, of course, the main thing is the memory impairment. The memory impairment, when you ask them, what about your memory? The attender will say, excellent memory, doctor. He remembers his college days, he remembers the marriage day, this, that, and all. I said, we are not interested in that memory. We are interested in short-term memory. Morning, what happened? Last week, last month, an important function which he has forgotten. Grandchild has come from America, and after 1 week they have left. You ask them who had come last week, any of your relatives, grandchildren. He says, no, no, nobody has come. They have come 2 years ago. So short-term memory, disorientation to time and place. Subsequently, there is restricted vocabulary. He will keep on repeating the same words or very few words. And in certain types of dementia, there may be aphasia, agnosia, etc., which we will come to it later. So the recent memory is the one which is affected. He doesn't have brush his teeth. He may straight away go for bath, or he forgets the important events in the recent past. In some types of dementia, executive dysfunction, difficulty to button, difficulty to wear clothes properly. So the right sleeve is worn for the left, the shirt is worn front and back. This sort of executive dysfunction also is very important. All you have to do is sit and ask history, history, and history. An example, like every morning, Radha gives her father-in-law his favorite breakfast and he eats with relish. She asks him, would you like more idlis, appa, or coffee? No, 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 I am quite full. After half an hour, a neighbor drops in to visit appa. Radha is in the kitchen and she hears them talk. Good morning, uncle. Finished your breakfast? Breakfast? Radha never gives me breakfast, not even coffee. This is how the fight between mother-in-law and daughter-in-law starts, or the mother and son. So son definitely believes that his wife is not giving the food. Otherwise, why should my father say that he has not taken breakfast? This is a very common occurrence. When you ask them, they say, yes, 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 this is happening like that. So that is about the neurological part. Now look at the psychiatric aspect. Personality changes. Very important. How do you know personality changes? First, you ascertain what he was 6 months ago, 1 year ago. He was very strict. He was not at all talking. He was very communicating very less. And now suddenly he has become very jovial. He keeps talking to everybody and he keeps telling all the problems in the house, property, bank, and all those things, people who are not concerned at all. So there is a change in personality, stubbornness, aggressiveness, withdrawn and uncommunicative, hallucinations and delusions, very important. People, if somebody is standing there, why you are not going and asking him to get out from the house, and inappropriate behavior. So these are all psychiatric manifestations along with memory impairment. And sometimes these may be more prominent than memory, or this may be more troublesome for the relatives rather than a memory problem. As I already told you, as the disease progresses, the passing of the urine in the wrong place, wetting the bed, and when you say, why did you pass urine? She say, okay, I have not passed urine. I don't know who has passed urine. And walking away, opening a door and disappearing. So we must have seen in Kannada TV, Kanalagiddare, senior citizens, they're all patients of dementia. They go out for a walk and they never come back because they don't know their house name, they don't know their own name, they don't know the way to come back. So they are completely lost. So in a city like this, nobody knows who is that person. If you are in a small town, they will say, oh, this is Dr. Srinivas, go and leave him there. But in a Bangalore city like this, even if something happens to me, my neighbor even doesn't know who I am. So it's very important that I tell these relatives that please pin a ID and a phone number whenever he goes out, even for 5 minutes. Change of place and intercurrent infection worsens the infection. So the patient was staying with one son, and after 3 months, that son will say to the brother, now it is your job to look after. I have looked after for 3 months. So there is a change of place. So there is a total change in the topography. They don't know, he doesn't know where the bathroom is, where the toilet is. So he may be so confused that he may stand in the drawing room and start passing urine thinking that it is bathroom. So the moment they go to there, see, he has gone there and he has become worse. They have not looked after properly. So please remember, any infection or change of place can worsen. Not infrequently, oftentimes patients complain of memory and the consulting doctor or a practitioner or even an Ayurveda practitioner will ask for an MR brain, and the report says that there is a cerebral atrophy and periventricular ischemic changes. So once they say that there is a brain atrophy, they think they are going to develop dementia, and they come to the neurologist. Then I keep telling them, look here, it is not the quantity of brain, it is the quality that matters. In fact, we don't know 30% of our brain. We still don't know what is its function. There is a brain still left. We have no idea what is the function. So please tell them atrophy of the brain does not mean his memory problem is due to dementia. Now, how do you distinguish these three? Depression, eminently treatable, MCI, reassurance, and dementia, which is a problem. All of them come with forgetfulness as the complaint. There is immediate memory loss as complained by patients with dementia, pseudo-dementia, that is depression, minimal cognitive, markedly seen in patients with dementia. Day-to-day activities are unaffected in depression and MCI, but they are all affected. That means a person who gets up, who does puja, and he does some exercise, and then he gets ready to go to the office, that is intact. That is not affected in depression and MCI. But in dementia, they without bath also they will wear the shoes and try to go to the office. ADL is affected. Progressive memory impairment is seen in dementia, not in these two. There are associated features of depression. Minimal cognitive, very quite active, but is worried about developing dementia in MCI. Personality changes, judgment. So these are the other problems. We have another 4 minutes before we go to the next session. So how do you confirm the diagnosis? Dementia is one of those clinical neurological problems which is diagnosed by history, and history. Common 5 neurological problems: headache, seizures, that is epilepsy, all movement disorders, transient ischemic attack, dementia. All these are clinical diagnoses. There is nothing to confirm. There are research tools for dementia, Alzheimer's disease, and all that, but they are not clinically applicable. So, no investigations to confirm the day-to-day one. As I said, history from caregivers. The more history you take from different people, the friends, the office colleagues, the home caregivers. So you have to take history from different people in early stages to make a proper diagnosis. We have what is called as a neuropsychological evaluation. There is only one test we do for all patients who come with memory impairment, but the neuropsychologist and the patient both have to be attentive for the test, because these are all tests. You ask them, name 5 cities in India. So the person may not name correctly because he feels what sort of a question this person is asking. But the person who is putting a test will know by facial expression that he is purposefully misleading me. So sometimes when the test is not very positive, you may have to repeat the test on 2 different occasions. The patient must be in a mood to answer the questions. So we do the routine MMSC in the clinic and then send the patient for neuropsychological examination. This is a test for visuospatial. What is visuospatial? Is visual perception of spatial relationship of objects. So visual perception of spatial relationship of objects. We ask them to draw a clock 11:10. So there should be spatial perception. This is 11. This is a small hand. This is a big hand. But that visual perception is not there. So you will find that all sorts of wrong drawing will be there, which is a very important clinical tool in the consulting room. What are the investigations? As I said, investigations for a treatable cause. Unfortunately, only 10 to 15% of patients who come to us for dementia. You forget about the depression and MCI. We are not talking about that. A good number of them who come to the OPD are depression and MCI. When you correctly diagnose dementia, only about 15% have a treatable cause. simple 3-4 investigations, FT4 and TSH, B12 and folic acid, and an MR brain, which will tell us about NPH, space occupying lesions, and tuberculous meningitis. These are the 3 simple investigations which we do. When clinically we have already made a diagnosis of more than a year or 2 years duration, so no point in doing extensive investigations. We just look for this. But so if you see the MR scan is a very important one. Subdural hematoma, tumors, hydrocephalus, tuberculous meningitis. These are the treatable conditions which you see in MR scan. Most important is rapidly progressive dementia. That's a very, very important point. You should ask, patient was perfectly all right, doctor, 3 months ago, doing all his activities, was very sharp and very managing very well. I don't know why he has rapidly deteriorated to an extent that he does not recognize us. That is a patient who requires extensive investigations because majority of them are eminently treatable. If somebody has 2 years duration, you can go slow and have only few investigations. But if somebody has a rapidly progressive dementia, don't ever diagnose degenerative disease. As I keep saying, degenerative disease is relentlessly progressive disease over a period of 1 to 2 years. So if something happens very short, there is a long list here. Keep the list, keep on looking for. Running out of time, I think I'll come back to you. Upgrade now to remove 40-minute. What should I do now? So we have one of the common infection is herpes simplex encephalitis, and toxic metabolic B12, alcoholism, iatrogenic like chemotherapy, lithium, space occupying we have already looked into, sarcoidosis, CNS vasculitis, autoimmune encephalitis. We have so many treatable conditions. Please look at that. They are all eminently treatable. So when it is something rapidly progressive, take time to investigate properly. When you do all this, then you may go on to a prion disease, what is called as Creutzfeldt-Jakob disease, which has no specific treatment. Nowadays, we do what is called as a CSF biomarker, a abnormal protein 14-3-3, but this may be found even in patients without CJD. So it is ultimately the clinical diagnosis which is very important. Now, out of all this, one which we should look into is the autoimmune encephalitis. Autoimmune encephalitis, why we should look for autoimmune encephalitis? It is a treatable disorder. It is a treatable disorder. It is a combination of extrapyramidal dystonia, pyramidal seizures, psychiatric personality changes, and a memory impairment. When you see a combination of UMN, extrapyramidal, psychiatric changes, and memory impairment rapidly over a period of few weeks, after ruling out all other diagnoses, think of autoimmune encephalitis. Because it is encephalitis, you'll see CSF inflammatory changes, and MR brain shows temporal lobe abnormalities. In addition, some other subcortical white matter lesions. And if you investigate further, they have NMDA receptor antibodies or other types of immune antibodies. But what is important, even if we not be able to do antibody testing, spending some 20,000-30,000 rupees, with a clinical and CSF and MR brain, come to a probable autoimmune encephalitis and give him our Gangajal, that is steroids, IVIG, plasma exchange. But because it is a not a one-off treatment, it may again relapse if you don't continue disease-modifying therapy, like you have to use cyclophosphamide, rituximab, and maintenance therapy. That means the same steroids and IVIG or even plasma exchange. You may have to continue every month for at least 6 months. So we went back to the step 1, step 2, step 3. we said, okay, treatable dementias we are looked into. There is one more condition before we go to degenerative disease, that is a vascular dementia. So vascular dementia is the second most common type of Alzheimer's. As the name suggests, there are definite evidence of vascular problems, either large vessel like strokes or small vessel diseases in the brain along with dementia. So clinically, it can be of two types. Either it is a post-stroke dementia, patient had a hemiplegia, following that he has dementia, or what is puzzling is the non-stroke due to small vessel diseases. Most often they have, how do you differentiate this from a degenerative dementia? They have more of an executive dysfunction. They are unable to button, they are unable to put the sleeves properly, unable to use the shoes and socks. So the executive dysfunction is very common rather than the memory part. And they have a gait disorder due to combination of spasticity and extrapyramidal, what we call as a lower body Parkinsonism. Lower body Parkinsonism. And a fluctuating course. So you look at this, there are so many points clinically to make a diagnosis of vascular dementia because they have impairment of executive function, they have memory, they have a gait disorder, what we call as a lower body Parkinson. Very slowly they will be walking. You may think it is Parkinson, but actually it is a lower body Parkinson. Parkinson is usually hemi, and there are fluctuating courses is there. And patient, of course, obviously has all the vascular risk factors. CT may show large vessel infarct, or it may show only the periventricular ischemic changes. Now, what is the importance of diagnosing vascular dementia? It is not relentlessly progressive like Alzheimer's, because people have already come with a lot of information that I'm going to be bedridden like this, like that in Alzheimer's. Like, you will have to assure them that it is not Alzheimer's, and it can be, progress can be halted by attending to all the risk factors. There are about 15% of patients who have both combination, so that you will have to clinically differentiate. Now, how do you differentiate vascular from Alzheimer's dementia? Vascular is there in patients with stroke and CVD. Alzheimer's usually it's not there. MR brain shows multiple infarcts, whereas pure Alzheimer's only atrophy. Gait disturbance is very prominent. In Alzheimer's, there is no gait disturbance. Urinary incontinence, both present. Pseudobulbar features are present here, absent here. Fluctuating symptoms because of the suddenly another small vessel gets obstructed, so there may be downfall, and like any other stroke, they again improve better. Whereas in Alzheimer's, it is a relentlessly progressive. Then we come to the last part of this, that is the degenerative disease, Alzheimer's disease. If the time goes away, we'll come to the second session after 10 minutes. Now, Alzheimer's disease, Alois Alzheimer is a German neurologist, 1864 to 1915. He studied extensively. He followed up this patient who was admitted in German Frankfurt Asylum. The clinical description which he has written in his handwriting on 26 November 1901, and the pathology, he followed this patient after the death. He persuaded them to get the autopsy done, and he himself looked into the pathology along with the other pathologists. The observations he has given on 26 November 1901, clinical and pathological, remains unsurpassed even today. All the clinical features which we read in the textbooks have been described by him by looking at one patient at that time, confirming clinico-pathological correlation. So you look at this, this is the brain of a normal adult, and this is a brain, maybe something like this for me also, normal aging with lot of atrophy here. As I said, it is not the quantity, it's the quality of the brain important. And you see the severe degree of atrophy patient in the temporal lobe and in the parietal lobe. In Alzheimer's, it is the temporoparietal, whereas in frontotemporal dementia, it is a frontotemporal. So we'll come to that, the difference between FTD, frontotemporal, and the common variety of Alzheimer. So it's the commonest cause of degenerative type of dementia. What are the risk factors? As I said, age, of course, is a very important risk factor. The longer we live, the more chances of getting it. There are some sporadic types also, some genetic part is there. Positive family history, if there is a sporadic dementia in patients of 40, 45 years, there is a 2 to 4 fold increase in the family. Educational level and intelligence is supposed to be one of the lower level of education level intelligence is supposed to be one of the contributory factors. In about 2%, it is autosomal dominant, where the dementia Alzheimer's occurs at a very early age. Pathology, there is a neurofibrillary tangles and deposits, beta amyloid deposits in the, that is amyloid is the main pathology which we are trying to find out now in preclinical stage to know whether the patient is likely to develop Alzheimer's or not, but we are not practicing it now because if I go for beta amyloid deposit and they say, look here, you are going to develop Alzheimer's in another 2 years or 5 years, the remaining 5 years is totally spoiled for me. So we are not doing to find out whether somebody is getting it or not. At the moment, it is at the laboratory stage. In Alzheimer's, what are the specific investigations? CSF. So the specific investigations are to look for amyloid, beta amyloid and tau protein in CSF, MR scan, hippocampal atrophy with global brain, FDG PET, which will tell us, as I told you, temporoparietal hypometabolism. Temporoparietal hypometabolism. And if you do amyloid PET, you see large amount of amyloid is deposited. So this is the specific diagnosis for Alzheimer's disease. You can see the atrophy here, but as I told you earlier, atrophy doesn't mean the patient has dementia. You can see the hippocampus, how it is getting atrophied over a period of 18 to 36 months. So this is the hippocampus which is atrophied. Now FDG PET, so the glucose metabolism, the PET scan will be seen. Normally our brains are very active, having lot of glucose consumption. In Alzheimer's, it is the parieto-temporal which is affected. This is the parietal region where there is a hypometabolism. In the other type of degenerative disease, FTD, it is a frontal. You see the frontal lobes here, normal functioning, and there is a atrophy or hypometabolism here. So correspondingly, the frontal lobe atrophy is seen here, and the parietal lobe atrophy is seen here as compared to the normal one. So temporoparietal is Alzheimer's. Frontotemporal is a different type of dementia. Now that is the FDG PET, where there is a glucose metabolism. Now the specific one is the amyloid PET. So in the amyloid PET scan, we see the deposit of amyloid. This is a negative scan, that is there are no deposits of amyloid here. Now look at the deposit of amyloid in this patient, especially in the temporoparietal lobe. So amyloid PET scan will also tell us that it is a type of Alzheimer's disease. So we have seen the symptoms and signs of dementia, which initially I told you how to diagnose dementia. They are all applicable to the Alzheimer's disease. There is a subvariety of a degenerative type of dementia called as frontotemporal dementia. Why you should know this, I'll tell you. Both are, there is no treatment for Alzheimer's, no treatment for FTD, but there is a definite difference in the diagnosis and implications. FTD patients come with auditory hallucinations, very important, auditory hallucinations and executive dysfunction earlier than memory impairment. So there is a general impression that dementia means memory impairment. Yes, in a large number of people it is true, but in a small number of FTDs, the memory is fairly intact. When you do the MSc in the clinic, but the patients are bought for what? They have auditory, somebody is talking, somebody is asking him to do this, somebody is shouting at him. So naturally, when they have hallucinations, auditory, they go to a ENT surgeon, and they will also get an MR brain, which may be normal, but over a period of time, they start getting the memory. Executive function means they cannot do small activities like you give them a paper and a pen, ask him to write. He will be fumbling with the pen here, there, because he doesn't know how to hold the pen, how to write it. So how to button it, how to wear shoes, how to shave. So he will go on looking at the shaving blade here and there. He doesn't know that he has to do it properly. The execution of the functions are affected earlier than memory impairment. So remember, in a clinic, if somebody is brought with difficulty in doing common activities, which he was doing earlier, ask for hallucinations, then you have a diagnosis of frontotemporal dementia. And 40% of them are autosomal dominant inheritance. These, the diagnostic features I have expressed to you. The important is the management. When we come to the Alzheimer's disease, we give cholinesterase inhibitors to increase the level of acetylcholine so that the memory is improved for some time. If you use cholinesterase inhibitors here, there is increased agitation because there is no deficiency of acetylcholine in FTD. There is no deficiency of acetylcholine in FTD. So the standard treatment of anticholinesterase drugs are not indicated. In fact, the moment you give that, they become very agitated, difficult to control. So you know the diagnosis. Now there is something wrong in my diagnosis. It is not. It is not Alzheimer's. It is a FTD. Because they have a lot of behavioral changes. You see, they have behavioral variation, disinhibition. I mean, very wrong way of talking, and they may take away their shirt and walk in the party hall. So you find all this is very disturbing for the relatives. For that, you will have to use SSRIs and like quetiapine, SSRI antidepressant like citalopram, and antipsychotics like quetiapine for behavioral changes. A good number of FTDs are associated with MND, corticobasal degeneration, and progressive supranuclear palsy. So you will see the atrophy of the frontal and the temporal. You see severe degree of atrophy of the frontal and temporal, whereas in Alzheimer's, it is the parietal region which is affected. So I hope why you have to make a distinction, sir. Anyhow, there is no treatment. What is the matter of putting a label? There is a matter here because the diagnosis you may miss and they come for executive dysfunction and behavioral variation and auditory hallucination with fairly intact memory. And in the management, don't give the donepezil, memantine and all those things. And the important thing is to give antipsychotic drugs and for the behavioral variation. Then there is another type of dementia, what is called as a Lewy body dementia. As you know that Lewy body dementia is a combination of Parkinson dementia complex. A good number of Parkinson patients over a period of 10 to 15 years of Parkinson disease can develop dementia. But here in Parkinson dementia complex, they have almost simultaneously, they have features of dementia and Parkinson's disease. So that is called as a Lewy body dementia because Lewy bodies are demonstrated in the brain. So it has got dementia with Parkinson features. Clinically, a very important point is a fluctuating cognition. They come with saying that his memory is very bad, he doesn't know where he is keeping it, he doesn't know how to dress and all that. Then you prescribe something, Ginkgo or B complex or something like that, and give some investigations. A week later, they come and doctor, you ಕೊಟ್ಟಿದ್ದ ಟ್ಯಾಬ್ಲೆಟ್ ಎಷ್ಟು ಚೆನ್ನಾಗಿದೆ ಈ ಎಲ್ಲ ಅವರಿಗೆ ಜ್ಞಾಪಕ ಬರ್ತದೆ ನೋಡಿ. Don't take any credit for yourself. That fluctuating cognition is a very important clinical point for Lewy body dementia. And the second important point is the visual hallucinations. The earlier in FTD, it is the auditory hallucination. Now here you see the visual hallucinations, which are very prominent. Other things like executive dysfunction and all this are there. Now, typical antipsychotics, risperidone, pacitane, anticholinesterase, and dopa agonists are contraindicated because they all worsens the symptoms. The moment you say Parkinson, you give dopa agonists, then they become worse. Anticholinergics, they become worse. and the typical antipsychotic like risperidone and pacitine. So you have to use atypical antipsychotic, that is quetiapine and clonazepam is preferred for his psychiatric features. Of course, if you do a PET CT, there is a widespread hypometabolism with marked metabolic reduction in occipital cortex. Now you see Alzheimer's frontoparietal, FTD frontotemporal, Alzheimer's temporoparietal, then FTD frontotemporal, Lewy body dementia is more into the occipital. Each one of them have distinct clinical features, and there is a practical implication about the drugs to be avoided. So this is a tabular form which says the patient has differential diagnosis of Alzheimer's, FTD, and LBD. Record ಮಾಡ್ತೀಯಲ್ಲ? Memory impairment is a very prominent in Alzheimer's, FTD, and LBD. It is not so prominent. Parkinson features obviously in Lewy body. Visual hallucinations very common in Lewy body dementia and auditory in FTD. Executive dysfunction is very common presenting symptom in FTD. Behavioral changes also in FTD. Fluctuating symptoms in this. The lesion I have already told you about. The important in practice is contraindicated drugs. Donepezil and rivastigmine, which we use plenty in Alzheimer's, is contraindicated because it will cause more agitation. And patients anti drugs for Parkinson like pacitine, dopa agonists should not be used because it becomes worse. Now, what about the treatment? Pharmacological treatment is useful for some people and for some time. Because there is a deficiency of acetylcholine, so we use acetylcholine esterase inhibitors so that they don't destroy the acetylcholine and allow the acetylcholine to build up. So the deficiency is made up by using the anticholinesterase drugs, donepezil, rivastigmine, and galantamine. These are the three anticholinesterase drugs. Usually we start with donepezil. If it is not effective, we change over to rivastigmine or galantamine. If one doesn't work, maybe the other one works. Now, you must tell them very clearly that the medicines are not going to cure. The main important is it will stop the progress for some time, and if you are lucky, it may improve also to some extent. So I usually give these medicines until 6 months where they are manageable. If they say, doctor, ನೀವು ಎಷ್ಟು ಕೊಟ್ಟರು ಇನ್ನ ಜಾಸ್ತಿ ಆಗ್ತಾನೆ ಇದೆ. So if the disease is progressive over a period of 6 months, in spite of any and all of the drugs, then you give up and say the drugs are not going to be effective, it's advanced stage. So as long as the disease is stable, you can continue 6 months or even 2 years. The other drug which is used is NMDA disciplinary, that is a memantine. So in the market, we have a combination of donepezil and memantine, which can be given regularly for Alzheimer's disease. For the psychiatric problem, SSRI for depression like citalopram, agitation, hallucination, quetiapine. So here a cartoon, right, which says, luckily he has dementia, so he's all dressed up and he's waiting for some imaginary friends coming in to look after him. But he's enjoying that he's waiting for somebody to come. The problem with dementia, the person who is affected is blissfully unaware of what is happening around him. Blissfully unaware. He is in his own world. The caretaker is the one who is maximum affected. Caretaker. See, in all other diseases like terminal stages of cancer, paralysis, or whatever, the patient appreciates the service done by the persons at home. And that gives the fillip to the person, a caregiver, to take more or better care. Now here, he doesn't even know who is taking care of him. On the contrary, with psychiatric features of agitation, shouting at the person will inhibit the person to give more care. So that is the real tragedy in dementia. The patient is in his own world, not appreciating what is happening and how much service the person is giving. That's why in dementia specialist clinics, we have uh, sessions for caregivers because they go into severe depression. So we have sessions to caregivers how to overcome their problems, and once in a way they also should have some break to come back to the normalcy. Prognosis relentlessly progressive, 10 to 15 years. Nobody dies of degenerative disease in the nervous system, whether it is a Parkinson or motor neuron disease or Alzheimer's disease. They all are ultimately bedridden. They all die of either urinary tract infection or chest infection. In some cases of MND, there may be motor weakness of the respiratory muscles. Otherwise, most of them succumb to the pneumonia or urinary tract infection because there will be catheter. So the death is usually due to complications. There are future possibilities. A lot of research is being done. Uh, Protease inhibitors, vaccine, gene therapy, and you know that stem cell therapy. Every disease, every type of thing, stem cell therapy has become the biggest, what should I say, sale. So as I keep telling in the class, if you don't find a girlfriend, have stem cell therapy, you will get a girlfriend next day. It has gone up to that stage. Each and every disease, stem cell therapy. Monoclonal antibody, we are trying to, because the main pathology is beta amyloid accumulation, uh, treatment to prevent beta amyloid accumulation. Some of the monoclonal antibodies are being done, but these are all at the laboratory stage, not in the clinical picture. The final two slides, common question asked, especially people with depression and MCI, sir, can I prevent Alzheimer's disease? Yes, you can reduce the chances. You can reduce the chances. The longer you are physically and mentally active is very important. You should be physically active. More important, you should be mentally active. The chances of developing Alzheimer's is less. It's probably because if you are mentally active, doing Sudoku or professionally or business wise or social gatherings, interactive, then you are using a lot of your brain cells. So a few of them, when they drop off, still you are able to continue normal life. So maybe that's what I tell in my class. Maybe our politicians do longer because their brain is always active. How to cross the border from one party to the other party, how to bring down the other fellow so that he becomes chief minister or whatever. So naturally, their brain is very active mentally, not physically. So the chance of Alzheimer's may be less. Is there any other way to reduce the chances? We said keep your brain active. There's a nice thing which I found. Maybe, can you prevent Alzheimer's? Maybe, if we tell people brain is an app, then they may start using it. Because you see your own mobile, full of apps are there, full of app. Now you tell him what is 4 into 6, that fellow will take an app and calculate and tell. They don't use the brain to say 4 into 6 is 24. So everything is on the app. When I tell them you come to my house, this is where it is location. Oh, don't worry, sir. We have the what is the GPS? We'll come like that. So maybe you can prevent Alzheimer's. If you think that brain is an app, please use that in addition to all those apps which you are using it. So the conclusion is all memory lapses are not dementia. When dementia is diagnosed, look carefully for treatable cause, especially when it is rapidly progressive. History is very important, rapidly progressive. Symptomatic therapy helps for some time. Caregivers training is essential to optimize the management. With this, I conclude the talk.